I started life medically as a GP, trained in general practice, and then trained in psychiatry, and then trained in psychotherapy. God, that went on for a long time. I was still taking exams almost into my 40s, but I've given up now. And appeared in the Betsy Cadwallader University Health Board, the BCUHB, which is the North Wales. There's nobody else apart from Mike and Steve here from North Wales, is there? No. The Betsy Cadwallader University Health Board, where recently I don't think we've got the same structure as elsewhere in Wales. We have these programme structures. It's all very military. We've got a chief of staff, and below that are these 6 programmes, all within mental health and learning disabilities. My programme is that one. There are also programmes in learning disability, acute care, which is the hospital-based system, substance misuse and alcohol services, community care. There must be another one. Can you remember? Who are my colleagues? Older persons.
Just have to go through the list again.
I know, there you are. So we sort of run in parallel. But it means that we can have an organisation which oversees not just secondary but also primary care in my case. So I've got a sort of oversight. And I have been, I'll talk about this later perhaps, the co-chair of the Welsh IAPT group. It's called Keeping Up with the Joneses because I guess everyone knows what IAPT stands for, or maybe not. Improving access to psychological therapies. And the brand belongs next door, in a sense, in the English Department of Health. I'm just going to give a couple of slides here, and I've got some handouts I'll give you afterwards. But just a couple of slides here, just giving you some background information about the IAPT programme in England, and then touch on what's going on in Scotland, and then come back to Wales. If you were told that you had an effective set of treatments which were not only clinically effective but also cost effective, which were likely to save the exchequer money, which were going to address the world's greatest cause of disability, which is depression, according to the WHO by 2020. You needed something to do, and you were Gordon Brown in about 2005 or 6, and this paper turns up in your in-tray, written by a Labour-friendly economist called Lord Layard. And it was answering all those questions. You might say yes, and Gordon Brown did. In terms of, we can underestimate, I think people don't generally recognise the effectiveness of psychological therapies for common mental health problems. They have an effect size generally of about 1. Now, an effect size which means that at that level, about 80% of people who are treated are going to be better off, on average, than people who are untreated. That doesn't mean 80% of people get better, but it's still an impressive benefit, especially when you compare it to other effect sizes, such as for CABGs, coronary artery bypass grafts, which is about 0.6, or for drug treatment for arthritis, which is something similar, or for aspirin for cardiovascular disease, which is much, much lower. So we've got a very effective treatment, and yet it's not really generally recognised as such. We've got problems with it, partly because so many people drop out of treatment. Maybe half people who enter psychological therapies drop out. It's a major problem. And so when we're looking at the effectiveness of psychological treatments, we've got to sort of actually take the real world into account and say there's a lot of people who just drop out. We've got to find ways of keeping them in treatment, because if we do that, we improve the system. In terms of the what happened next door, they realised the cost of not treating depression, which was, back in 2006 figures, it was costing something like £26 billion to employers, about £7 billion in lost revenue to the exchequer. Along came NICE, as you know, this is something we all curl up with every evening, in 2003, and reviewed the evidence base and cost effectiveness of treatments for depression and anxiety disorders. Every single mental health NICE guidance has got psychological therapies as part of it. It's been updated recently, hasn't it, in 2010. And there's new quality standards being drawn up. 2006, the two demonstration sites got going, one in Newham, one in Doncaster. Slightly different designs, but in the end they ended up delivering pretty similar service. 11 Pathfinder sites were commissioned the following year. Those Pathfinder sites focused on areas of hard-to-reach individuals, if you like, people who don't generally access services, black and minority ethnic communities, older people, children, offenders. So more data was sort of gathered by 2008 when Alan Johnson, in his, when he was Secretary of State for Health, allocated £173 million to the IAPT programme, which was supplemented in 2010 with another £70 million when the downturn happened, and then supplemented again when George Osborne spoke in his maiden speech as Chancellor of the Exchequer, or his budget speech, and allocated another £400 million. So in total, we're talking about the English programme has had a funding stream of over £600 million. It's an awful lot of money. And in fact, George Osborne, he singled this out. One of the very few, and it was the bad news speech, wasn't it, last year, when everything was being cut, but not IAPT, because its data collection system had supported its use. It's a terribly important thing to realise that. The English IAPT programme has spent a huge amount of effort collecting data about its activity and clinical outcomes, and that has reaped dividends in terms of protecting it from cuts. We'll get on to that in a moment. I'm not quite sure what it says at the bottom, but the recommitment and expansion has meant, although this began life in a primary care working with common mental health disorders, it's now been expanded and focusing on CAMS, children and family services, adolescents, psychosis, personality disorder, older people, and long-term conditions and medically unexplained symptoms. All of those things have now been scooped up into the IAPT programme. Early days with that, because we're only 3 years into what is a 6-year programme. The rollout will be completed by 2015, when it should be mainstreamed in the English system. By March 2011, 60% of England will have an IAPT site. And there was a major clinical review of the service done by a chap called Giles Glover, published last summer. And that was based on 2009 data. But it was that data set which has helped to support the expansion in 2011. About a quarter of the IAPT sites reported there were achieving recovery rates of about 50%. That was the key outcome, key performance indicator that the government set. So in other words, half the people who went through a full IAPT treatment were no longer clinical cases in terms of the symptom measures and that they set out. So this was deemed to be a very impressive achievement and helped to support the rollout. £400 million sounds quite a lot, but the English programme is expecting to recoup about £700 million. It's what it said in there's a document published called the 4-Year Plan. It came out in February 2011. And it suggests that they will get the money back. Now, is that amazing? You can't sort of think, oh, well, this is a no-brainer, isn't it? It's a no-brainer. No, I guess we've got to wait till 2015 to see if they actually are correct in this assumption. Get the money back through people who then can pay taxes, people who aren't using health services because they are better, people who are employed again. So there's a variety of ways in which money can be recouped, not necessarily through all one budget. Of course, for Wales, we're at a disadvantage, aren't we? Because we don't look after the social security budget. So just a little bit, listen, last slide about England, because these are the Joneses. We don't really want to hear about the Joneses for crying out loud, do we? But unfortunately, I think we have to. The 6-year plan, based on the idea of let's just implement NICE. Which the NICE depression guidance, which I'm sure you're all familiar with, has a stepped care pathway which includes low intensity and high intensity, or step 2, step 3 in the thing. Skill sets, if you like. Low intensity skills are essentially related to cognitive behaviour therapy, but actually in the depression guidance there are 5 treatments which are stipulated for acute management of depression. CBT is the one which has got the greatest emphasis in the guidance, but the IAPT programme is now, English IAPT programme is now focusing on the other 4, which include couples therapy, interpersonal therapy, psychodynamic interpersonal therapy. Anyone help me here? Can't remember the other ones. Sorry? Problem solving would be a low intensity skill. Yeah, rather than a therapy in its own right. Counselling, did I mention that? Smiling at Louise here, part of the BACP. Yeah. Interesting, the data in the Glover report showed that counselling was as effective as CBT for depression, maybe less so for anxiety disorders, which is perhaps what you might think. But. So it's all established within the principle of least burdensome intervention to meet needs. So this is the jargon, as it were, behind the stepped care principle, isn't it? So you don't fail people and then push them on. If you can allocate people the correct, the opportunity which is most likely to benefit them at the first time. And a sessional review to detect non-improvement. Sounds a bit grim, doesn't it? Have you not improved? What this means in practice is that if you ever are part of an IAPT service, is you get a PHQ-9, the 9-item depression inventory, and a GAD-7, the general anxiety disorder questionnaire, every time you visit. And the benefit of that, you see the drawback, can't you? But the benefit of that is that you're tracked, your clinical progress is tracked. And it does seem to make a difference in terms of clinical outcomes. If you just have the first and the last meeting, just harvest the information on those 2 occasions, you tend to lose the second occasion. And also you tend to not retain people in therapy as well. And the outcomes are better, it would seem. The Glover data seems to support that, and there's other research which seems to support that. Again, this is a really important lesson about how we routinely collect information about clinical status.